Today's WebEx is patient safety and quality in telehealth. I am also, as I said, a pediatric nurse practitioner. I practice at the Cleveland Clinic. I work in distance health. I see patients online. I direct their quality, and I also create population health programs using remote patient monitoring, patient-generated health data, and virtual visits, whether they are direct to the patient or scheduled virtual visits. And we'll talk a little bit about that throughout the WebEx. I'm hoping that this provides you some information just to think about. I have no disclosures in regard to this particular program. The key takeaways that I want to share with you today are to describe how dynamic and transformative the landscape of healthcare technology is currently. It's interesting. I look back on the last 3 years, and it's been a roller coaster ride of all kinds of different changes. And I suspect with technology advancements and some of the other key drivers of telemedicine, it will continue to change for a prolonged period of time. I'd also like to explain how technology can improve access to care, efficiency of care, cost, and engagement. And again, there's a caveat, obviously making sure we balance that system, list the inherent risks in this new delivery model that we're looking at currently, and describe ways to embrace the opportunities, but making sure that we simultaneously promote public and patient safety throughout everything. Sometimes you can get so excited about new opportunities and all the different innovations that you're planning that you forget to make sure that you have that as a founding principle in the work that you do. So to start off with a little bit of background information is I really wanted to help people understand what is telemedicine, what I'm focusing on today's conversation. And telemedicine is really just looking at a patient who is seeking care in a remote location and connecting with a provider through technology, whether it's through a laptop, a tablet, a smartphone, and this can either be in regard to a video conferencing visit, or it also can be done through remote patient data that's flowing in. It can also be looked at through, at some point in time, and some people have considered this in telemedicine also, is a provider to provider or a curbside consult to be able to look at telemedicine. So these are just all different ways that you can define telemedicine. A little bit about the history of telemedicine is it's not really new. It's come up in popularity and in the media and in usage really probably in the last decade or the last probably 5 to 6 years. But it really stems back into the 1950s. The first program out there that I could find was a program in Nebraska. It was a psychiatric program that was counseling for individual patients and to provide group therapy for a variety of patients with psychiatric needs. And this was the first time there was any systematic study that was done on telemedicine and the programming of it in use and the benefits actually that had surfaced from there. I envision back when I think about that long ago and the first computers that were back that I would, and how large they were and everything else, and going, this just must have been an amazing feat to have this occur in the 1950s. The next one that I could find that was more broadly applicable and in line with what I do is in Mass General in the 1960s, combined with Logan International Airport, and provided some primary care, but predominantly urgent care, connecting using telemedicine. So really, what are the definitions? And I think the only reason why I throw this on in the WebEx is to make sure that there are definitions for telemedicine. If you were to actually do a historic review of what it is, there are so many different terms that have been used for telemedicine, telehealth, and those are the two that I'm going to focus on in a moment. But then you have mobile health and e-health and digital health and virtual care. So telehealth is really kind of the broad umbrella. It's just electronic information using telecommunication technologies and supporting long-distance clinical care, patient and professional health education, public health, and health administration. So it can either be done through video conferencing, through the internet, a store and forward imaging, like in remote imaging that you can get image upload possibly in your institution, streaming, and then some wireless communications. So this is the definition that HRSA adopted in 2016. And then down below it is the more less inclusive, but the telemedicine bucket is created by the American Telehealth Association also in 2016. And just use of electronic information and telecommunication technologies to support medical information exchange from the patient in regards to the patient's clinical health status. And so this would incorporate not only the telemedicine from a patient to a provider, whether that's on demand or in a scheduled visit, but also some of the asynchronous or the clinician-to-clinician visits. So the next slide is key drivers. So really looking at what are the drivers? What are the drivers that promoted telehealth? What are the drivers that are pushing it in 2019 in particular? And one is access. We know this is a significant challenge within our healthcare today, whether that's to primary care services, to specialty care services, just things such as physical therapy, or all the other allied health groups here. But what we're also looking at, and we're trying to figure out from a patient safety perspective, is what are the use cases? What can we use in telemedicine? What can we everything be accessible through telemedicine? And I beg to say that the answer is probably not, but I don't know that we have enough evidence. There's some that's emerging to really know how telemedicine can be used to improve access. And I say all that because I really want to pin this back as to when we're creating all these things, regardless of the enthusiasm and all the different stakeholders involved, we really need to think about one of our primary goals of keeping the public and patients safe in providing care. So reimbursement investors, this is a very large area for industry of growth and expansion, all the different peripheral devices, the different apps that are coming out, AI generation and how that's going to be used. There's a lot of money going back and forth and a lot of investors and innovators in this space, again, that may not necessarily have had the background in patient safety and efficacy trials that are so important in the care that we provide our patients. How do we get the right care to the right patient? There still are connectivity issues. How do we communicate? I think about the course that I teach in communication and collaboration, and one of the topics that we dive into is patient handoffs and all the potential challenges that stem from there based upon the fact that, we're using the telephone versus in-person communication. What are the challenges that occur with telemedicine and doing virtual visits through the connectivity that we have? So it's a key driver so that we can improve care in a variety of different matters, but always grounded as to what are the challenges that we may not necessarily have been able to identify yet. Advances in digital tools, there are so many things that are coming out consistently through patient-generated health data. So if we look at blood pressure cuffs, in my organization, we can now give blood pressure cuffs for people with uncontrolled hypertension, send them to their home, have a tech specialist connect them and make sure that they're flowing directly into the electronic health record. And so a provider can actually go on, create the order to get this device into the patient's hands, but we have to make sure that the patient knows how to use it. The provider knows what to do with all the information that's now streaming in real time into the patient record. So there's new devices that are out there. There's different peripheral devices that can allow you through an app to be able to do a physical exam, to capture breath sounds and heart sounds, to look in people's ears, to look at people's eyes and do an eye exam. So they all can, we have the capacity to do them, but what are the challenges that are associated with them? So aside from driving clinical decision, stepping back going, oh, how do we make sure that we think about doing this correctly? And then we have the unanticipated disruptors in the healthcare field in regard to technology that are driving change at a very rapid pace. I mean, we now have Amazon and Berkshire Hathaway and providing care. We have Apple Health. We have Fitbits that can stream in to, how many steps you're taking and what's your physical activity, and you could potentially add information into diet and nutrition. And some of the phones that are out there, such as Samsung, already are preloaded with, you can click on the device and connect with providers in a variety of different states that can give you care for minor urgent needs right at the moment just from your mobile device. So all these things that are coming on, there's a lot of investments in 2019 from pharma to really look at some of the programs, and especially in regard to medication and medication adherence and management. And then you have the advancements in data analytics and the ability to mine patient records and the expansion in that regard that these different apps and software are going to be able to provide us. So all kinds of things going on that's really making this a very hot environment, for lack of a better way of saying that, but to trying to figure out all these things that are going on, but are we providing safe care? What are the things that we need to be looking at? So the next slide is in regard to use cases. So what are we currently doing now, and what is pretty well established that are going on across nationally? And those are virtual visits. Those are, as I said before, on demand or scheduled. So they can be in the ambulatory setting or in the inpatient setting. We see patients, as do many, where you can connect straight to the phone and you have a sinusitis and you can actually connect with a provider in real time. In less than 10 minutes, wherever you are, you can have your exam completed, potentially have the prescription waiting at an urgent care. There may be point of care testing that's involved with that in regard to ordering a urinary analysis, or you may have a x-ray or imaging that's done. All these things that can happen all through the use of these technology tools that we didn't have in the past. However, I was thinking about them, and again, into my course, of what happens when you have medical errors that are associated with critical lab values. How do you get those? This just adds another layer of complexity onto the system that already is very complex to begin with. Inpatient, you have great advantages of a provider being in one place, but can also connect with our patients. Family members across the country connecting in with their loved ones who may be in the hospital for different procedures or different medical problems. Great opportunities, but then again, what are the challenges that are associated with it? I'm thinking of how do we look at it. I remember when I first started doing telemedicine and saying, hey, everybody looks yellow. How do I actually get them to look like their normal color? Everybody's not jaundiced. So there are just different factors, and how do we look at some of these technologies and the limitations and use them appropriately so that we can provide safe care. And then also the backup systems, like I said, when it comes to doing lab work and x-rays, et cetera. Remote patient monitoring and chronic disease management, it's pretty well established. We have these devices that we send home, whether it's for glucose readings for diabetes or blood pressure monitoring for hypertension or weight scales maybe for congestive heart failure or obesity. All these things that can seamlessly come into your record, provide real-time feedback, much more efficient and timely care for our patients. But when I was thinking about it in regard to safety for patients, and I thought about a hypertension program, we were talking with providers and we were going, okay, so how many readings now that are out of control or out of range that would state that someone's hypertension you use before you change or adjust medication. These are things we don't know. There's things that don't have, standardized evidence-based information out there. And we're actually, in regards to that question and some of the others, we're not even to consensus-driven guidelines. So a, a lot of opportunity for potential error. And I think we have to be really mindful about how we use some of the data and some of the tools that are out there. Clinical apps is another area which is very concerning to me when you realize that only 1% of the clinical apps that are used for healthcare or healthcare associated education or healthcare related advancement, for lack of a better way of saying that, are associated with someone who's been in the healthcare field. So there's a lot of apps that are being developed, and if you think about apps in general, most of the people who are creating them do not have a background in healthcare, do not know patient safety, do not, and may not have the same regulatory landscape that we have to keep our patients safe. Remote image upload, that's a little bit easier. That's been contained within healthcare, but there's still some problems of making sure that the right images go to the right place and potential medical error associated with that. Second opinions are another use case that are done via virtual, and it can all be asynchronous, where you're sending a bunch of records over and someone actually evaluates them with not necessarily ever seeing the patients or laying hands with some questions. You can just imagine some of the potential safety errors associated with this. There's also algorithm-based asynchronous visits or questionnaires that you go on. Sometimes they're called e-visits, and it's supposed to be on very minor non-acute illnesses, where a patient goes on, answers a bunch of questions, either can get kicked out, or actually you may have a diagnosis and medication ordered by that. If you don't have the complete history or the patient misinterprets the question, all kinds of potential for error there. And if we're going to do any of these things, what are the things that we're measuring? Are we continuously watching for quality and safety as we're developing these and piloting these different use cases? AI, which is, again, how do we use augmented intelligence or machine learning or to be able to move this forward? There have been some studies that are out there all saying that, telemedicine, that many of them, I should say, systematic review saying that telemedicine is cost effective, it's quality producing, it's patient satisfier, et cetera. And I think about one of these, they came up with some catastrophic events in regard to AI, and it was in the diagnosis of melanoma based on pictures that were sent over. And they only had an accuracy rating of about 10.8% when the actual biopsy was done. So it's concerning, and what are the safety mechanisms that we have behind that? What are the protocols? What are the safety that we use in the monitoring and the tele-ICUs and the telestroke, and making sure that we keep all this data very well at hand and following them over time? And I know I'm not coming up with many answers, but I think these are just questions that I think everybody needs to grapple with as we're embracing all the different opportunities technologically that exist that we can have now at our disposal in healthcare. So looking at some of the benefits and risks, telehealth has been promised to revolutionize healthcare, and I do truly believe that it will. I do believe within 5 to 10 years, much of what we do in processes for ambulatory care is going to be changed by technology. And a significant probably inpatient also. I'm just not quite as personally familiar with that. And there's a lot of rise in adoption and integration. There's many organizations that have come out nationally and said 50% of their care will be done virtually by 2025. within the next, 5 to 10 years. That's a big shift from what it is that's going on. There are a number of studies that say it's convenient. It saves time for the patient. It saves cost for the patient and probably for the provider also. But the evidence is really limited. And it's interesting. I actually belong to a national organization to develop metrics that are out there to monitor telemedicine and some of the programs and the use cases that I just spoke about. But there's not even consistency about exactly how we phrase things and what questions we ask. It's very limited. But we're getting there, and we will, and I don't think that we're going to go any backwards in any way, shape, or form. So what are the standards of care that were used for all the difference? And really, we should have a similar standard of care. There should be parity. If you come in for hypertension care, regardless of the way you're provided, it should be the same and the same expectation with the patient. Some of the other things that we really need to think about are data breaches and cybersecurity, and what platform that you're using if you use to adopt it, because there's huge potential for misconduct by some individuals out there with data if indeed they get a hold of it. Misdiagnosis and medical error. I know that there's been some, and this goes along with the prescribing challenges below. There have been multiple articles that have been published in the New England Journal of Medicine, and the Journal of Pediatrics, and Annals of Internal Medicine, all in regard to some bias innately with people coming on into prescribing, particularly around sinusitis was the one that's often cited in the recent literature. Just really not having some cognitive errors and not following traditional care that you would have in the brick and mortar facility. I don't think that's true. I think it's, some providers just may not have the same standards or may not have the same tools, or may have a broken system, all kinds of reasons that this may occur. But it's so important to have a framework to be able to monitor this, to have adequate communications at the beginning with all the key players when you're developing programs, so you prevent any of these challenges from actually occurring. And of course, there's fraud and abuse that can happen with this as with any other healthcare entity. So looking at some of the consequences that are out there in regard to the clinical realm is, we have consensus-driven guidelines at this point in time for telemedicine. They're not evidence-based. As I said, it's still emerging. What are the structured assessments that we're looking at? What are patients' preferences? And I really think that's a key stakeholder in all of this as we start engaging and collaborating with partners in different industries that are building these apps and having these data integrators and platforms that are out there. What does the patient say about all this? What is the patient expectation? Are we all having a conversation at the beginning and then monitoring that? It needs to still be in a HIPAA secure environment. We've had patients, I know, on our platform that have connected in Ubers in different locations at sports events, and that's not a HIPAA protected environment. This isn't social media. We really need to stick to what is our safety factors that are associated with this. What are the risk factors, and does the patient have truly informed consent when they come on the platform as to what they can expect from a telemedicine visit? I know sometimes they expect a lot more when they come on, and I'm seeing patients, but we don't have the capacity because at this point in time we're not using peripheral devices to be able to hear heart and lung sounds. But making sure patients understand that. What are the workflows? They should tandem into similar clinical workflows rather than creating a whole new one for providers before they come on, because if you have a standardized workflow for doing something and being able to track it, all these things can lead to medical error if we aren't careful and thoughtful about how we implement telemedicine across organizations. Another thing in regard to potential challenges has to do with Language barriers. Part of my course looks at how do we communicate with people of different languages, limited health literacy. Those we haven't really identified doing this in a telemedicine environment. So again, to extrapolate out from that some of the potential patient safety issues and concerns that are associated. So in regard to the administrative realm, is what are the regulations? We really don't have any. Joint Commission has not identified telehealth measures and key performance indicators and things to monitor with that. There have been some guidelines assistance. There's the American Telehealth Association and ClearHealth Institute for Quality is out there. CMS is really they're starting to look at this, but it's just emerging information that's coming out. And, some of the standards are really more in regard to technical and HIPAA and informed consent. In regard to technical, I think this is probably one of the biggest challenges that are out there is what is the bandwidth, the interoperability, and the communication capability. Can everybody hear adequately? Can they see adequately? There is a difference in lighting in a website manner that you can have when you're actually doing visits virtually. Simple things that, I thought was a eureka moment when I first was trained, and they said, if you have two monitors, how are they set up? Are they stacked on top of each other side by side? Because what are you teaching, what are you saying to the patient if you're looking up and down like you're saying yes versus, the negative of tilting your head back and forth, which makes a difference. And some of these subtleties that you don't realize that can overall impact safety. Cybersecurity, we already talked a little bit about. And, encryption systems. If you're going to use some of these asynchronous modes, how are you actually sharing the information back? Think about the patient portal. I mean, the list goes on of really what this telemedicine and telehealth touches. And so patient safety and quality is really providing interprofessional collaborations, cooperative governance, participatory design when we're creating these, and adequate training. I know that training people to use telemedicine, understanding what the expectations are, what are the consensus guidelines, what kind of resources can we provide to clinicians, to residents, to nurse practitioners, to nurses, because everybody at some point in time, I think in the near future, will be using these new technologies. And it's really incumbent upon us to develop the infrastructure to be able to create safe environments. How do we use the clinical decision support electronically? What are the guidelines and protocols? Like I said, what's the interoperability between different systems? I know in the state of Ohio, we actually have a rule that requires all providers share information. And then always continuously to look at quality and drive it forward. So ultimately, it's a matter of balancing what is our commitment to ethical principles, not doing any harm to our patients, using technology to drive innovations to enhance quality and efficiency, making sure that we get the patient's voice in it, look at clinical workflows and make it easier on providers, look at all the potential technical issues, and follow what the emerging technology is. Is it really making sure that we think broadly of taking care of our patients, which is our ultimate goal. And Sean, do I go ahead and do this, or?
Yeah, I was just going to say thank you, Carrie,
okay.
for a great presentation. And I'm actually looking at my two stacked computers right now, thinking about what you just said. Why is it set up like this? Should it be set up like this? Though I'm not necessarily, helping patients on a daily basis. It's always good to think about things like that. But yeah, I wanted to say thank you. We're going to open it up for questions. Also, and thanks everybody for joining us. My name is Sean Betcher. I'm one of the advisors for the Patient Safety Leadership Program. Also online with us and is the program director, Dr. Annette Valenta. So she is here as well. But maybe before we go into these slides, I can start to cover them. But if you have any specific questions about sort of what Carrie just covered, we can actually go ahead and you can use the Q&A box. I think some people have been typing in there to really type any questions that you have, and we can relay those regarding the presentation. Or Carrie, if you also have things that you would wanted to ask or talk with everyone, that'd be great as well.
Yeah, it's interesting as I started developing the program and I looked, I thought it was a very interesting concept to think about patient safety because all of it, I got taken away by the allure of all the potential and the benefits that it can provide, but really making sure that we capture this and having the distinct benefit of teaching the communication collaboration course. I looked at the topics and I look at them through a different lens that I'm not sure that I would have normally thought of. And unfortunately, I looked at telemedicine, as exciting as it is, and the potential that we have, innovating to provide great systems for our patients, and really ultimately doing the job of taking care of health for our nation. And I wonder, it's a little disconcerting that we don't have any evidence. We can't point to it. We can't do a root cause analysis because at this point in time, we really don't have the information to start thinking about how to do that. We can start planning backwards when we find things, but there's so many things that are just starting in pilot phase, and we're such in infancy that there's nothing to point to. You can't point to, this is the guideline that we're following, and this is the protocol that we're using, and this is because they're not there.
No, that's a great point. Anne actually had a couple of questions, it looks like. She had wanted to tell you, excellent presentation. And then how about credentialing and licensure concerns?
Yes, there's a huge number of credentialing and licensing concerns. I personally am licensed in 15 different states, and it is a cumbersome process. Some states are easier to get through, and I think it's a challenge whether you're a physician. Most of them you need. There's some that are starting thinking about compact and moving forward with that. I think medical providers and physicians and DOs are actually at an advantage. That's moving a little faster. I happen to be a nurse practitioner and physician's assistant. I'm very familiar with, but nurse practitioners have to not only go and get their RN license in most states, and then they have to wait, and then they get a nurse practitioner license, and some need a prescription to prescribe. So it's a very different process. So the process in itself is a challenge. The other process that is associated with that is the education that you need to maintain your licensure in each of the different states. And what I mean by that is, so I have now taken child abuse training in 5 different states because no state recognizes the other state's educational program. So that's a challenge. When your license actually expires, it could be annually, it could be every 2 years, it could be on your birthday, it could be in some nebulous month that they decided to change it in, or it could be all standardized across the state. So trying to keep up with some of these subtleties of multi-state license really is a challenge, and I know that it's really being focused on at a national level of how do we streamline this, how do we have compact agreements between states so that people can do this, because at this point in time you need multiple licenses, and it's contingent upon where the location of the patient that you see, not where you had. There are some benefits that if you indeed have a relationship previously for that patient, you can see them for the exact same reason. However, if you're a patient and you're talking to them about hypertension, they come on with a new problem, that is a new problem, but it's not covered typically under your umbrella of, I've already seen the patient for that problem. So I hope that answers the question about licensure and regulation. It is a definite challenge.
Another question, also from Anne, are you aware of any medical malpractice cases regarding telemedicine?
There are very few that I know of in regard to telemedicine. I know that a lot of citations that have occurred between boards that have been monitoring prescribing behavior and some that actually look at duration of visits um, and have actually cited providers, but have not, I don't know of any actual malpractice where they've lost wages because of that or removed licensures to be able to practice.
Okay, another question. Given these challenges, how is the buy-in among providers?
It's that Rogers innovation curve in the fact that we have really early adopters currently, at least in our environment, we have 800 providers, which doesn't, to me, overall doesn't seem like a lot, but I would say probably 200 of them actually do telemedicine on a routine basis where they see. I think it's part of it is where are you in your state in regard to reimbursement? And where are you in regard to reimbursement and payment parity? In the state of Ohio, and I can't speak for every state, but there is a great website that I can actually attach to this, and it's Connected Care. It does a great job of every state is looked at in regard to what the laws are, the reimbursement status, and licensure activities. And it's kept up pretty well. In regard to our providers, I think some of the challenges are just if we don't get credit for RVUs because you don't get reimbursed for this by all providers, then it's really hard to figure out how to use it. If there's not a template built, how do you create one for telemedicine? If you have a peripheral device such as that captures the heart and lung sounds, you can do a lot more things. So then do you have a separate template for those that have peripheral devices and then a different template because you obviously can only do certain things with a physical assessment? How are you capturing data associated with those? So some of the people just find that very overwhelming. And some people just say, I'm going to be a trailblazer because this really is something that satisfies me. And patients have all been really happy. So I think you have the gambit. And I know we have it actually the departmentally. There's some departments that just thrive in this, and there's some that are just like, let's wait back and see how this is going to play out.
That's right. Other questions? Oh, it looks like Sally had said I did not hear the last question, so I think the question was about, it was previous to this one, are you aware of any medical malpractice cases regarding telemedicine? That was the question that was asked of the previous question. But other questions that anybody has? While we're waiting to see if anybody ends up typing here, we usually give that kind of a silent count. I did want to just quickly kind of go over. Carrie does teach in the, and you do the communication collaboration course, correct?
Correct. Mm-hmm.
Yeah, which is 403, which is the third course typically in the sequence of courses. So that's the third course if you're doing the certificate program or the master's program. But the patient safety leadership program basically has two options, and they're sort of the bullet points. But it's either taking 9 courses for the master's or 3 for the certificate. The certificate program, it really is the first 3 courses of the master's program. And it's entirely online. If you end up moving on for the master's, you do come here to Chicago for about a week, halfway through the program, really after your course, Carrie, after the 503. Typically there, 2 courses after your course in the 501 is when you would come here to Chicago. And then a lot of our students that are in the program that end up going on for the master's program do complete what's called a capstone project. So here it's just sort of a slide showing all of the different capstone projects that have been recently completed around a number of different issues. And then finally, here's sort of the titles that really a lot of the people end up getting sort of after the fact, or they also have these titles coming into the program as well. So Chief Quality Officer, Manager of Quality, Staff Nurse, Risk Management Analyst, Medication Safety Officer, Hospitalist, Kari, are there other titles that you seem to see that of people that are dealing specifically in telemedicine, patient safety, or that intersection is occurring?
No, it's interesting because I think that the one thing that I've seen is a new title that's being thrown around is a virtualist. Um, are you doing this to augment your care, or are there people that are going to specialize this like a hospitalist did in the past and equating this into just a very expertise-driven environment? And I don't know the answer to that.
Yeah, you don't know. I okay, just throwing it out there because I know it seems to us that those titles or whatever is occurring when you've got a new sort of frontier, they can have a different bend to them based off of where they're kind of resting and what institution they're at. So it's always interesting. Other questions that anybody has? I know we were kind of slotted for right around half an hour here, but I'll give it a moment. If not, that's the this is kind of what we had sent all the information out to you. But if you have more questions, feel free about either the program or for Carrie, you can email the online info at uic.edu or call us, and we can always forward those along as well, specifically. If you have more questions, or if you have questions about the program. But Annette or Carrie, is there anything else that you wanted to add?
Yeah, it's Carrie. I just wanted to
Carrie.
echo that I'm happy to answer any questions for any of you at any point in time in regard specifically to the program or in regard to telemedicine, because it really is, I think everybody has to band together to be able to make this a success for our patients.
No, that's great.
Thanks, Carrie. It was a very interesting topic, and it certainly is at the leading edge of the of healthcare's thinking. Although I have to admit, this morning I was talking with somebody who still has an AOL@AOL.com email address, and I had to actually look to see, is that really still a carrier? And I bumped into the fact that there are still 9 million plus people using dial-up, and so I cannot. It was more than I could even imagine trying to use dial-up for the websites that we build today. So, and I don't think images over dial-up would work so well. So we certainly have numbers of problems, I think.
Yes. We've come a long way, but a long way to go.
A long way to go. 9 million is a lot of people.
All right. Well, thank you everybody for joining us, and thank you Anna, and thank you Carrie again for the great presentation. And we will be sending this out as a recording to everyone, so please feel free to share that with your colleagues as well. And again, if you have more questions either about the presentation or about the program, feel free to email us, and we'll get back with you. But thank you everyone.
Thank you.